And I think
Bore da, croeso i cyfarfod Bwrdd Iechyd Cyhoeddus Cymru heddiw, braf heddiw. Welcome everybody to the meeting of Public Health Wales Board. And just to let you know, this meeting is being conducted via microphone. Also, you've got a number of people in the room today as well. Just a little reminder to people, the first time they speak, please can you give your name and your job title as well. I want to let everybody know the meeting is being recorded for the purpose of ensuring accurate record of the minutes, being recorded via Microsoft Teams. Recording will be stored until the meeting minutes are confirmed at the next board meeting, which is the 30th of July. And after that point, they are deleted. So just for everybody to be aware. We have a few apologies for absence today. Hugh David, who is one of our non-executives, can't be here today. Kate Young is also away. Liam Scott from our Aspiring Board Members Programme is unable to be here as well. And our staff side representative, Claire Sullivan, is also not here. But I'm sure that we will very much consider staff voices in the items on the agenda today. I also want to welcome Ilona, who is here joining us to support the next item or the first item on the agenda. And welcome Sean Griffiths, who's on Teams, who's member of the board, a non-executive member of the board. I'd like to extend particularly warm welcome, croeso to Zoe, who is joining for her first board meeting. I'm sure we'll hear a lot more from Zoe later on, but yeah, very, very warm welcome to Public Health Wales, and we're absolutely delighted that you've joined the team. So thanks very much for that. Can I just check before we go any further whether there are any declarations of interest for items on the agenda today, please? No, I'm seeing lots of shaking heads, so thank you very much for that. And we're going to start off with something that's quite close to my heart, which is the Children and Families Programme, Pippin. And I did notice we have it up on the board, it says Pippin. I'm very keen because it's Pippin and Pippin Active. So that involves our work with Sport Wales as well, which I think is absolutely fantastic and worth noting. So I'm going to hand over to Jim, who I'm sure will introduce Ilona and take us through this item agenda. Thank you.
Diolch Cadeirydd. Jim McManus, cyfarfod y Cynefau Cyfrifiad y Person. I'm Jim McManus, National Director of Health and Wellbeing. I'm just going to say the following three things. The first is that most of the work we do in health and wellbeing is done in partnership with others. And the really good thing about Pippin and Pippin Active is, while it is in only 3 areas, it works closely with families and parents. And I think that's the real impact of this. And I'm really excited about it. This is one strand of lots of work going on in Healthy Weight in Wales, but I think it's an important strand, and I can see why it's dear to our chair's heart, because it's dear to mine as well. I guess the second thing to say is that another strand launched this morning with our clinical partners and Diabetes UK and People with Diabetes, which is our Know Your Risk campaign. So we're the lead story in BBC Cymru in Cymraeg, and we're the lead story in BBC Wales in English. And we'll be on television tonight. And we've had people living with diabetes in Wales on radio this morning and on TV tonight, talking about the work we're doing on risk. I would hope that involving people runs and involving voluntary sector partners runs through our DNA. We can and need to do more. And I think this programme showcases some of the work we're doing, not just with parents and schools and families, but with Sport Wales as well. So I'm going to stop there, and I'm going to hand over to Ilona, who's our brilliant co-director of health improvement. We'll actually tell you real stuff, and I'll stop talking.
Thank you so much. I'm going to, as I say, introduce the Children and Families Pilot Pippin, and you are very right, it's Pippin and Pippin Active. We look after, or we support Pippin, and we work hand in hand, in essence, with Sports Wales, with their Pippin Active project, which is part of these slides. So I'm absolutely, and to be honest, this is one of my favourite projects because it's absolutely lovely. So if I just probably start with the low side of this, which is just acknowledging that the reason why we're doing this in the first place, that overweight and obesity in our population amongst our children is actually much, much higher than we would ever want it to be. The recent figures from the CMP has sort of said that it's about 27.3% of children are living with overweight or obesity by the time they start school. There is a difference, I don't believe it's significant, between those in rural areas and those who are in more urban areas, and children from more disadvantaged backgrounds, which is no surprise. There's always those inequities that are present. There is also another thing I just wish you to note is that while we have a lot of children who are living with obesity and overweight, they actually reach services late and very late. So where we get to intervene in the system is often not where we really need to be in the system. So where we're actually getting to them is late. And the later you get somebody, the harder it is to shift it back. So I think there's something about this early intervention which is really important. So Pippin is a Welsh Government funded pilot. It is a pilot in 3 areas of Wales. And it uses a whole systems approach for prevention for overweight and obesity. It's delivered in 3 areas: Anglesey, Cardiff and Merthyr. They've been chosen because they have different types of context for testing this. So Cardiff was chosen because it has a southern arc and it has quite diverse population. Has its rurality, and Merthyr has some of the highest rates of obesity and overweight in the whole of Wales. So they were chosen for their particular context. And it is very much part of the Healthy Weight, Healthy Wales programme, and it's linked to other Public Health Wales initiatives and pathways. So there is a real link across this programme, and it started back in 2021. There are 2 link components to this programme. There is a whole systems approach, which is about engaging our local organisations, our communities, to actually turn them into the places and spaces that actually mean that you can support people with their weight. And then there is a nested home-based intervention component. So it's very much a targeted family-based intervention, bringing children in. It relates to overweight and obesity. It is aligned with NICE guidance and very much the evidence. So we know that whole systems approaches work, and they do matter. We also know that family-based interventions are good interventions to use. That's what the evidence tells us. And the things that the intervention side of this, and this is about families who are at risk, where the children are at risk of being above a healthy weight. So those are the ones who are, we're targeting those populations in those communities. And we're targeting that nested home-based intervention, and that includes elements of diet support, activity, screen time, and this is where we've got lots of strong partnership with Pippin Active because they are doing this as well. And that's the exciting part, that we are actually learning to work hand in hand. The whole systems element puts the wraparound around them. So there's no point in telling people to be more active if they've got nowhere to go. There's no point in telling people that, should eat A, B, and C if they can't do it. We have to create the spaces and places for that to actually happen, because that's actually what makes a difference. And by shifting what happens around those families, we create the wider benefit for more of those families to benefit. So there is that nested intervention feeding into the whole systems and vice versa as part of that build. The aim of the programme really is to strengthen the systems to support families and young children, to really get that multi-agency involvement. When I talk about the spaces and places, I'm talking about the agencies and everybody orientating to work better together to make things work. And really using the learning from those families when they tell you, I can't get out because I'm scared, or I can't do this because of A, B, and C. Human learning on the ground with those families to tell us what we need to do to make a difference. And we're really trying to increase the number of children leaving the foundation phase of the healthy weight, reduce the prevalence in those areas, and really think about those socioeconomic inequalities by really getting to what matters. And it really is about narrowing those inequalities as well. So what's happening with this project? I'll go on to the systems element. When we started this project, each of the areas didn't have massively strong connections, shock horror. And they didn't work with organisations in the way that they could do. And what we've done over time, and this is just one of the areas, and I've borrowed slides from each of the areas because they're so proud of it. We've got the most wonderful presentations. Some of the stakeholder maps about who they're connecting to, how they're connecting. This is actually how they've actually started to engage with and reorientate and work with other organisations to make them healthier, and to actually orientate how they work with those families, how they bring families into making a difference. So this is about how we get that stakeholder vision, but actually organisations thinking about what can we do, what can we make to make a difference, what can we do to orientate this to actually work better together. They've mapped out what the local resources are. So just thinking through some of the angles, they've looked at where can you get fresh food locally? What are the opportunities in those areas? What's the takeaways around them? Takeaways are not a good thing when children are eating a lot of takeaways according to our data. Where are the play opportunities? Again, where our sport, and again, we're mapping out where are the opportunities, because as I say, we can tell people to do things, but it doesn't make it happen. We've looked at the area settings, schools, the opportunities, they've mapped out what's there, and then they've built on that as they're building up the assets and opportunities, and actually making it so that people know that they're there, because people don't always know what's around them in those local areas. Then they've also mapped out, okay, what can we do to make a difference? The causes, the challenges, all those things that make a difference. And they've done this within our project, but they've also done this with Sports Wales in the Pippin Active. So again, in Pippin Active, they've mapped out all the activity opportunities, but this is where it all joins up together. So I'm hoping this is going to work. Some of the things between us, and actually some of the learning, because we've got Sports Wales and ourselves working together in each of those areas, we've actually been working with them very much together. What Sports Wales didn't actually have healthy food policies in place. They now have those. They've shifted how they work, but we've shifted how we work. We're working together better. We're thinking together about access. We're thinking together about opportunities. We're thinking about parental buy-in and how we role model in that, about all of those things together. We're thinking about competition and duplication of offers. We're so territorial at various points in time. This is my bit, this is your bit. But how do we actually optimize what we're offering in the system in a better way? So that, and the cost to families, how much it costs them, how, to get out and about and do those things. There's all sorts of strange contradictory things like vending machines creating income, but not, in sports centres, but then they're not healthy products. So again, how do we engage with our partners to make that different, and focusing on, and a lot of it focusing on income rather than health and about those goals. But how do we do that together as a partnership, and how do we work together so that it really works? So one of the things that we've got is, and this really maps across how Pippin Active, they've got footy families, they've got the Nursery Roadshow. How do we join up what we're doing on the ground around those families to make this work? So they've got lots of active opportunities, but how do those connect into the healthy eating opportunities that our dietetics and other offers happen? So what they've then got is those crossover events where we work together. And this is, I think, Anglesey's area where we've got crossover events. We've been actively working together. So we've clarified what we're doing. We've clarified how we're working. We're working very much together and in partnership to create those exciting opportunities for families. What does this mean in real terms? This is data from CONTAF and they've got offers. What we're finding is people are staying in the system, they're coming in. We're getting to families and they're actually not dropping out of services in the normal way that they do, because we're getting the offers shaped around the families. Similarly, they're taking up the offers around those active opportunities as well. And what is self-reported behaviour change from the data that we're collecting in those areas. So what you're seeing is engagement, people clinking in, and it actually starting to move forward. Now, this is an interesting bit. So CTM then started looking at the adult BMI for those children who were coming into their area. Some of them were overweight, some of them were very overweight, and some of them were healthy weight, but they were very at risk. And if you look at the adults coming in, 56% of those adults coming in are living with obesity. So the parents are living with obesity. So those family lifestyles are the ones that are proper. These are the ones we're getting early. And what you'll then see is that obviously a large proportion of those 25% are actually living with overweight as well. So these children, if we carry on as we are very, very high risk. And if we can change the family lifestyle around them, then we're making a difference. And this is where we're really getting under the surface of something. And of those, strangely, of those participants over a healthy weight, 32% are actually in the adults of the family. The parents had actually reduced their BMI as well. So we're hoping that these children do not either lose weight or in terms of grow into their weight because they're young, or actually never become a non-healthy weight. And that's where and I think we've got the right space in place and the wraparound around those families. And this is what really starts to kind of make a difference. In terms of reach, what we've got is we've got schools engaged, we've got engagement, we have connections across, and this is with Pippin Active as well. We've got connection to families, sessions, active sessions, but also community connections as well. And this is really between us, that partnership is actually what is being really, really strong about this. Welsh Government funded both projects separately. We've chosen to work together and we've chosen to work in this way. And that strength between the programs, that sharing that knowledge and learning has really strengthened how we work and how we move this forwards. So I'm on time. So our outcome state, we are getting an engagement through both Pippin Active and through the engagement. We are getting children who are at risk coming in early. We are seeing, and this is very much a tested scale model. We've got it wrong some of the time and we're learning, which is good. We're seeing family behaviour change. We are seeing improved healthy eating. We're seeing improved behaviours. We're seeing active families. We're seeing a huge change in the community opportunities where Pippin Active has really made those differences. And we're seeing those stronger partnerships to not only to Pippin Active, but also to some of the connections in there. You'll see that all of our partner organisations, because that's one of the things that Sports Wales has really got, it's got some really strong organisations. So we're actually joining those together to work together. And our partnership is working. We have learned there's no one fits all solution. One thing working in one area doesn't just lock and stop. You can't just post it into another area. It doesn't work. But we do know a lot of the principles that work to make a difference. And I'm going to just share, and as I say, these are the pictures, and we really do sort of, as I say, it's very exciting. We have some wonderful videos, which we might be able to share around, but I didn't think I had time to share them, but there are some lovely videos that go with this as well.
Well, I mean, if they're online, then maybe you can send the links out to the board. That would be really great, and perhaps attach them to the presentation and send that out. Anybody got any kind of questions, Tamsin? First,
Tamsin Robson, cyfarwyddo anweithredol, cyfredol led by Agamrien, diversity and inclusion, non-exec director. Congratulations on this. I was just saying to Sabina that I've met a couple of families in RCT. I wasn't there to talk to them about weight loss or anything. I was talking about family centres, and they brought up Pippin with me, how much of an impact it has on them, on their families. So the child had been referred, but what the mothers were saying was that it has impact on the whole family and a changed behaviour in the whole family. And they wanted it as part of a service in this new centre that I've been working on. So it really has landed with some families. Congratulations. My question was, if we're taking this family-centred approach, does that then come with additional resources? Is it a resource-heavy model if we have to kind of intervene and support at that very kind of household level?
So the way, and I should say, we're using learning from this to kind of build the future that would look like. So this is where we are with it. But the family-centred model is offering different types of sessions. So some, they do offer one-to-one sessions, and some offer much more group sessions as well. And some of those are delivered very much by the community, within the community, by sport body. So what you end up with is, and actually the group model is an interesting one because a lot of areas have really, while some families feel they need some individual support, what we've learned through this, because we started with one thought where, oh, needs one-to-one, and they love the group models because they've got that community connection. So there is something about that, you know, listening and learning to those families about the resource involved and that community element that kind of, and the using the community organisations and working with them creates those spaces and places that really build those resources. For example, CONTAF, I know they've got a park run now, which they didn't have before. So again, a lot more opportunities, and some of it is about support, but some of it is about that wider opportunity that comes with it as well. So yes, it can be a bit resource heavy to start with, but I think what we find as it builds is it has that strength.
I think there's something in that. For me, one of the examples from Ernest Morn that I was talking to somebody about was the food bank use, and food banks supplying healthy recipes along with food.
Yes,
and that's a small thing being delivered by a third sector organisation. And they were also talking about talking to the people who are coming into the food banks who they give the recipes to say, have you got a kitchen? You know, that kind of understanding the housing that people live in. So I think there is something more about our involvement with third sector that sorts of things really resonated with me. And it's about the scaling up, I think, is going to be the really important thing, and community engagement. Catherine, I'm going to come to you first, then Ian and Jim, I have noticed you. Catherine.
Brilliant, thank you very much. Catherine Bissell, non-executive director. What an amazing piece, what an amazing project. And it's lovely to see the whole system approach with kind of community assets being really utilised to tackle what is an increasing challenge. So one of my questions has kind of already been answered around scalability. I suppose my other question is related to, so you mentioned kind of data is being collected. So for me, as soon as I saw this, the first thing I thought was there's room here for a realist evaluation, because it's about what's working for whom in what context to enable scalability. Because it's so important we understand the context. So you mentioned data was being collected, and I was just wondering if you could expand on that a little bit. And
So we have an initial valuation in terms of a process that identified that we need to strengthen some of our data. But there were some areas where there was a reluctance to collect certain bits of weight data. There's a little bit of stigma around certain bits of data, but we are working through that and we're finding ways through that. That's getting stronger. And we are commissioning an evaluation for the end of the year, so there will be a further evaluation to support the scalability of the work and to really help strengthen the model in terms of what a scaled up model looks like. I will say that CONTAF area has already scaled up because they secured internal investment through their clusters. So the work that we did was then scaled up through cluster investment, so it's gone to now 2 areas, and so there is actually, they are sort of able to test that, but they've actually managed to secure funding to actually test that themselves already.
that's great to hear. I mean, I think measures, it's really interesting, things like sleep quality and fantastic.
Thanks, Catherine. Ian.
Unsurprisingly, I was not really familiar, but will I kick off. So Ian Bell, sort of research data and digital. I was in the evaluation space as well. I think if you've got 3 kind of areas, you've got an opportunity to go into a real proper outcome-based evaluation here. I think we need to probably work together between our teams, make sure we don't just get a scalability. We say this is the impact we can see, and how do we properly policy impact model that as we go through everything in my point.
Yeah, that's great. Thank you, Ian. Jim?
Thank you. I don't want to preempt the evaluation, but I think there's a couple of really important lessons coming out of this for us. One is that with something as complex as the Nova Way, the days of individual interventions only are over. They have a part, but like tobacco, we got the lowest prevalence ever in Wales from smoking because the system changed. not just because of smoking cessation. We're demonstrating that it's the same with obesity. That's the first lesson. The second lesson is that actually interventions work better when you work in partnership with people and organisations on the ground. And you can't adopt a one-size-fits-all approach. The third lesson is this is slow and hard work and painstaking, but it's a lesson for how we can work as a national agency with others. And the fourth lesson is actually when you get, the slide where we're actually targeting the right kids with the right families and the right parents. That means we need to be in the business for endurance and actually be saying, if you really want the outcomes, you're going to have to be prepared to spend the money to make this happen because it will generate impact. So there's 4 really important bits of learning for us about our style and how we work with partners. You know that I want to build an ecology of self-care and self-management and people empowerment across Wales. We're rubbish at it in the UK. I want Wales to be the best. These things that look small, I think, are teaching us big lessons.
And there is something, in fact, in terms of this is investing in the health of the people of Wales.
Yeah.
The reality is that we spend the money now, then we don't have heart disease. We don't have all sorts of problems with hips and knees and all sorts of things that will make an impact on people's lives moving forward. But there is something, I think, on Ian's point about measurable impact, and we know it will make a difference in 20 years' time, but how do we know that the ship is on the sort of sailing in exactly the right direction throughout those 20 years? So that analysis of that more short-term impact, I think there's something for me about seeing lots and lots of things over time, projects that are great pilots, that work fantastically, that we understand the principles that sit behind them, even though there will be community and regional and family variances within that. We recognise that, and then we come to the end of a project and we evaluate, and actually it doesn't turn into something that affects our wider population. It only has that measured, that real impact in a local group. So for me, it's about how do we develop this moving forward. It's really important. Tracy.
Yeah, Tracy Cooper-Dewey, thanks, Jim. And it's great, isn't it? Because this is the fabric of society stuff. So a couple of points. I think it's really important to do some learning about pathway of identifying the right children and young people, and how we can learn lessons across other interactions, engagement. My point really is about sustainability. So what we wouldn't want to happen is families get involved and then funding stops and we disappear, because it's the kind of thing where there's that ongoing support there. So I'm just interested on how are we going to maintain that, and we meaning the breadth of we with partners, because the really great progress that people are in control of, if there isn't that ongoing, as we know, interface, interaction, regular drop-ins, engagement, how are we going to help people sustain the amazing improvements that have been made so far?
So in terms of this is a project, obviously we've got a lot of learning, and it was lovely to, the working with the food banks and those areas, and there is something about sustaining those partnerships and that engagement as part of our work, and there is something about actively acknowledging that matters, and acknowledging that actually the world keeps moving on. So the partners that you're sometimes working with shift as well. So there is something about a very proactive approach to these projects. And in terms of sustainability of this project, a lot of the work that's been done, I mean, a lot of the food banks or things, is because those are the things that matter and are significant for those areas. And each area is actually quite different in its background and what it needs. But working with the partners further forwards, I think there is something about how we make sure that is continually engaged. We have been learning a lot about how to use social media differently. our partners have been using, so they're creating networks around those. So for Cumtaff area, they actually have a community around that. So they don't just have the people who are involved in it. They have people who are then the community around it. But then what they also do is have some of those partners come in and they've actually joined in to actually be partners to help with the, their projects. So they've actually joined back up. So they've actually completed the loop. It does need active management. I'm not going to pretend this has been an easy. I can tell you a lovely shine. It has been an awful lot of hard work to make this work, to find the things that work, to test things and not, and work out when it doesn't work, because you have to do that with communities. So I'm not going to pretend there is a wonderfully, but the principles of what we've got are the right principles. And, we've learnt, and with Sports Wales, there were glitches initially. It took time to learn to work and, with different types of objectives, but we are, by actively choosing to do so, that is making a difference. And I think the more we engage in those ways, the more that we need to tell the stories. Because if I will make sure that if the videos are available, but the stories, the people, they matter. And that really, really does help with our arguments as well.
And I think there's an ethical issue here for us. Because if this works, we need to be saying it needs to go into policy choices. Because otherwise we let down the people who we exist to serve. And if there isn't going to be money, we have to provide an exit plan that sustains this using the partnership wherever possible and the power of people and the power of community. And I think we need to get systematically, one of the things about public health globally is that you do a pilot and then it kind of falls off the edge of a cliff. It is no longer ethical to do that. And if it ever was, I don't think it ever was. So I think we have to be factoring this into our saying to government, this works. It's not cheap, it's hard, but it works. You've got to make it work with us. And otherwise, I think we shouldn't begin these pilots. I think that's a real ethical challenge for us.
And in terms of cost, the cost of this compared to the cost of a weight management service for children,
Actually cheaper.
oh, it's a lot cheaper.
Yeah, and I think, that's one thing that is something that I feel very strongly, and I hear this reflected around the room, is that we don't want a project like this that is plainly demonstrating that it's making a difference. They don't want to see it be in one of those things that funding goes into, everything's great, and then all of a sudden it's just lost. And I think that's really important. I think before I come to you, Catherine, just one thing that I don't know if we can do more widely, but the mapping, I think, of where the schools are, where the takeaways are, where the active opportunities are, and probably where kind of third sector support organisations are. That's something that we could consider doing more widely across the communities of Wales. It'd probably give us a much better idea of how sustainable this system could be across the whole of Wales, because at the moment, you've said we have different places, different needs, different communities, different needs. And so we're only actually understanding 3, aren't we? But if we had that against what we do in this region, and this region, then if we create maps of other regions and they look the same, then we'll have an idea of what we're dealing with, I guess. So I just wondered if that's one of those kind of things that we could think about putting some capacity into in the future. Catherine, I'm going to go to you, and then we're going to have to think about moving on.
Brilliant, thank you very much. And I think that for me, the sustainability links to data, because in order to demonstrate impact, you need data. And from that data, you can then model what the likely long-term health impact might be. So I think that data becomes really important. I think in terms of that mapping, which makes a brilliant idea, I keep going back to this is a realist evaluation. What's needed is a realist evaluation, because that will then, if you then have that mapping alongside that, you'd then be able to say, right, we have these contexts across Wales, and therefore this is the implementation plan for these different contexts. And I just wanted to end by congratulating you on the publication this year.
Thanks, Catherine. I'm going to add my congratulations. One of them, absolutely brilliant piece of work. I said, it's quite close to my heart, and it's so good to see the successes that you have had, and long may it continue. is what I say. So thank you for the presentation today. Send us the videos. I'm sure people will love to see them. We all like, I know we tend to call them patient stories, but we shouldn't, should we? They're people stories. They're people stories. And it really, gives us, really demonstrates things close to people's hearts, don't they? And everybody will value the presentation as well. So thank you, Alona. Thank you for your time today. And thanks for presenting to the board. It's one of our really good projects, and it's nice to hear successes. As I said, long may it continue.
Thank you, Agatha. Thank you for your time.
Moving on to the next item on the agenda, Tracy, I'm going to turn to you, please, for your statement.
Yes, dear Pippa. So as usual, I'll take it as read and just draw attention to a couple of items. So the first item, we were just keen for the board just to be cited on a lot of work that's ongoing around our pandemic preparedness, our all threats preparedness emergency response plan, continually informed also by COVID inquiry reports coming through. We've got a really strong EPRR team, which helps us on normal business as usual, but also, as you'll hear in a second, anticipation of threats, real or future threats. So we were keen for you to see the progress that's made there, and it segues nicely for all the wrong reasons into the second item. And so I'm going to ask Meng to update the board on the hantavirus outbreak, but also colleagues joining us and members of the public will have seen in the news about the most recent Ebola virus outbreak. So, Meng, I'll hand over to you. Thank you.
Diolch Tracy. Mae'n codi cyfarwydd fo cenedlaethol gwasanaeth Cymraeg diwygyddi iechyd a Sgrinio National Director of Health Protection and Screening Services. So the hantavirus outbreak associated with a cruise ship has now come up with 12 cases, 10 of which are confirmed. Still remains 3 deaths. On the 10th of May, British nationals were transported back to the UK for continuing care, predominantly to continue their self-isolation period of 45 days. And they were all transferred to Arrow Park Hospital, where they had a period of assessment, following which people have been offered the opportunity to self-isolate in their homes. A small number of them have returned to Wales for self-isolation, and in Wales we have established a care and wellbeing pathway to facilitate the ongoing management of that self-isolation period, to ensure that they have all the welfare and wellbeing support, and also health support during that period of time. And we've been working very closely with health boards and local authorities in the local areas concerned to ensure that that is seamless and that the arrangements are made known to the individuals concerned. We continue to engage very actively with the UKHSA IMT structures to the evolving situation. But as time goes on, and we're anticipating by mid-June that period of 45 days of self-isolation will be complete. Alongside this, we also have the notification of an Ebola outbreak in the Democratic Republic of Congo. And on the 17th of May, the World Health Organization declared this as a public health emergency of international concern. There are several hundred suspected cases, some of which have been confirmed as Ebola cases, but owing to the lack of infrastructure and facilities in the DRC, the confirmation of suspect cases has been slow in forthcoming. But because of the global travel and the diaspora of citizens in Africa, between Africa and the UK, and because of the spread to other parts of Africa, we have been very closely involved in making preparations for anyone returning from affected countries, including returning healthcare workers, to ensure that we're monitoring actively anyone who presents with symptoms. And of course, alongside that, because Ebola is a high consequence infectious disease, we need to ensure we've got the pathways of care for managing suspect cases who present to our facilities in Wales. So to that end, we continue to work with our health boards and local authorities, and as well as NHS PNI, to ensure that those local arrangements are robust and fit for purpose. So I'm very happy to stop there and take any questions.
Do we have any questions for anyone on this? No? Oh, sorry.
Thank you, Mary. So the next item I just want to draw attention to is item 5, which is the fit out of our new accommodation in Seasons House up in North Wales. And it's really more a thanks than anything. I know the board, but I wasn't able to make it, but had a development session up there a couple of weeks ago, meeting with all of our people who work out of there and also our facilities staff. And so people watching them may not think it's a big thing, but it's actually quite a big thing for us. We want our people right across the organisation to be working in an environment that is sustainable, and it's consistent with our culture. And sometimes it's quite challenging, particularly where we co-locate in our laboratories. But through a huge amount of work from our facilities team and our people who moved their pre-existing offices into Seasons House, who kind of co-designed the layout as well. Just a really big thanks, because it's really nice to hear our people. This is a great place to be, and so it's really nice. So I just wanted to say a special thanks to our facilities team, particularly to Caroline, to Neil, to Kath, to Tom and to Zara, and all of our people up in Seasons House who co-designed it. And of course, it's been done with a sustainability nod and making sure that the footprint is as sound as it can be. And then the final point I want to draw attention to is Zoe. So it's item 6. So she joined us as our new Executive Director of Strategy, Finance and Performance, and Zoe's going to take us through the next one item. So 2 weeks in. 2 weeks in. 2 weeks in. So we're delighted that Zoe came back for the second week. So that's also good. I mean, already, Zoe, it's just great to have your experience and you around the table. And I know a lot of the conversations we've been having around optimising the organisation and what that means about impact, value, efficiency, effectiveness, etc. I know that you're going to be an amazing leader right across the NHS in Wales as well. And I know that how we can support director of finance and director of planning around that prevention-based resource allocation. And so you're a great asset for us, but also for Wales. So delighted that you've joined us.
Yeah, thank you.
And then the last one is just the public inquiry. We've got a detailed stock take later on in the agenda, and I know Paul and Meg will be able to update. So I'll stop at that, Pippa, and I'm sure myself and colleagues happy to take any questions.
I firstly just to agree on the visit up to Seasons House. It was really good. Very well done for the team and everyone there. My question actually comes from in the health protection attached report. There's an element about screening laboratory UK accreditation, about temporary suspension for service screening. How temporary is that?
So we're looking at the mitigations actively. We have asked our colleague in the Infection Services Division, who obviously are familiar with the UCAS accreditation, to look at the remediation required. Now, the accreditation and the return of that requires a re-inspection, so we need to agree that date and the mechanism for that, and the conditions in which we are content for them to come back to re-inspect, to then return the laboratory to an accredited status. So I don't have a timescale that I can tell you now, but I know they're working at pace to achieve the re-accreditation.
Would that have an impact on service?
So as far as the expectations of the National Screening Committee is concerned, there is no expectation that the accreditation is necessary for the continuing of the processing of samples for cervical screening, and because it was run alongside it for the fit testing as well. But there are arrangements and discussions ongoing about how Infection Services plays a more direct role in the management of these screening laboratories.
I can just apologise. I forgot to say Nick Elliott, non-exec director.
I think she's made the point I was going to make.
Oh, okay, that's great, thank you. Are there any more questions on Tracy's report? And I'm sure you've all read the director's highlight reports as well of the work that they've been doing, always incredibly busy. So any questions on any of those? No, I think it's just really helpful, I think, for the non-executive directors to receive that information about what's been going on in all of your extremely busy lives. So I think if we're happy to take assurance from Chief Exec report and the directors' reports. Great, thank you very much. We move on the agenda, which is our public health overview and the dashboard. Ian, I'll hand over to you first, if that's okay.
Okay, thank you very much. So I'll give a brief overview as always. Starting off on the excellent public health services, I think I'll start off on the positive side of the progress on CDFCO, actually, where it's coming down across the board, particularly nearly all health boards, but particularly sharp in Swansea Bay, which I think is really significant progress compared to where Swansea maybe was a couple of years ago in some very different discussions we were having around this table about it. So I think there's really good news there. I think on the antimicrobial resistance, after a period of declining, it appears to have stalled a little bit, and we just need to understand more. I know Mang and their team and there's work with the CMO to further embed how we get the funding to account around healthcare acquired infections and AMR into the system more. However, the childhood immunisation data is still below target and remains so, and I think there's significant work needed to it. But this is not one where we hold a ringleader bid, but actually delivery sits out in health boards, and it's how can we work with health boards to drive up performance across the board there in a challenging environment. Then moving on to supporting a sustainable health and care system. I think as we can see, the very long ways are beginning to come down with the over 36 weeks, which is good news. But some of the analysis which we presented last time shows, although that very long is coming down, actually, if you look at the over 26, that's quite static. And so what's the impact on the median and how much real improvement is there is still one of the outstanding questions as the follow-on bit of work from the presentation last time on healthy life expectancy and the latest waiting lists. That being said, any reduction of the very long is clearly going to be significant and important for the people involved. Yeah. Mortality data is on a pretty standard trend. It's within its usual bounds of variation and not showing anything I'd like to highlight on it. Promoting healthy behaviours, again, it's on a similarly pretty flat trend, and again, similarly around the mental and social well-being. I'm going to spend my last couple of minutes just on the wider determinants. So we know about the global effects which are taking place, and there's obviously going to be a bit of a lag, but certainly on cost of living, you can start to see people's concerns about it taking up again. And I think that's inevitable, given it. And we have to remember that the questions of this are about over the past year. If you were to ask the question about over the past 5 years, how much have people increased their concerns about the cost of living, it would be a significantly different thing. So we've got to read that with a degree of caution that this is another shock on top of what's already been quite a challenging situation for many. Then finally, on the labour market side, I think it's clear the number of vacancies are beginning to dry up within the labour market, and that's starting to feed through. Again, there's a caution about the data quality. The data quality has improved again in the Labour Force survey coming out of Office for National Statistics. But then you've got question marks about whether what you're seeing in the trend data is that just a quality improvement or underlying. I think the big thing for me is it's clearly going to be quite a challenging labour market, and with the headwinds around the economy and the wider global, I think that's going to continue for us as an area of concern, and that usually leads through to quite different concerns in child poverty and other measures as well. So I think my summary would be in there's a mixed picture on some of the more direct healthcare related indicators, pretty flat on the behavioural. I think some pretty worrying headwinds coming through the wider determinants, and I'll open it out for questions to Claire, Chair. Thank you very much.
Thank you, Ian. Claire?
So this is slightly unfair, really, so I'm not sure the answers in the data, but I suppose it's a wider question. The improvement in the very long list wait it's notable and fairly impressive and sustained over months, because that's good. But I think for me, the question still remains: do we think that has been achieved as a result of systematic changes that are embedded, or has that been achieved on the back of sustained short-term measures like those vote? Do we know whether this is a long-term pattern that we hope to see continue, or whether actually it can be quite quickly reversed, or is that an unfair question for that to tell me?
No, ask me.
Oh, thanks, Tracy, for your support. So, I think basically we don't have all the drivers. I think on this would be what it is showing is that a relentless focus on accountability here has driven a result in improvement and impact. And certainly we look across many of the things we talk about. Often it's that accountability work which does it. And the job with the accountability is if it's sustained the accountability, then they will have to make the measures more sustained if they're in short-termism. My gut instinct is it will be a mixture of both, and it'll vary across the country between different areas, with some with very short-term things, whereas others will have taken a more, how do we make this sustainable approach? So I think there will be a very mixed picture, but that's from opinion rather than data. Yeah.
That's true.
Yeah, thank you very much. Thank you very much, Ian, for that update. So you mentioned just a couple of things from me. So you mentioned childhood immunisation and whether there was anything that we could do as Public Health Wales to support health boards. And it looked like Powys had a very impressive year in 23-24. I was just wondering if there were lessons to be learned from what Powys did during that period, when we know what they did to increase that uptake. So that was, yeah.
So I'm not sure I know fully on that. I can take it away. May know a bit more, but I'm happy to take it away and get the answer fully from the team. Yeah.
Well, our team kind of works with the health boards who kind of put improvement plans in place at a very granular level. There's also an oversight board that Welsh Government leads that brings the system together. And actually, the Director of Public Health from Powys is the member of that oversight board. And whilst I don't have the story, the improvement story, we can absolutely share that if there's something different that they're doing. But what we're finding is that in terms of the implementation issue, secondly is the model of delivery issue. Because many health boards are not able to rely on primary care to be the prime deliverer. So that there are other things that come into play there. And of course, access to the population is another issue. But these are considered on a very regular basis, and my team is heavily involved in that. And we will support them in working with the Ian's team on the data where we can.
Thank you, Meng. I know you've got another point, but I will come back to you on that. I'm going to come to you, Nick, then Tracy, then Meng.
Thank you. Yeah, thanks for Brendan. You just actually kind of off the back of your questions that happen to be in a similar place. It looks like the emergency admissions are doing a step change upwards, coinciding with the elective work that's going on. And I'm wondering, because it actually looks as though it's making a step change rather than just the annual increase. And I wonder if there's any insight in there there's either a parallel with what's going on about potentially short-term rather than systemic change.
It's certainly worth us doing a bit more. Probably we can look and see whether things to see how much there is a direct population, and then do a bit of So I'm not going to speculate on their ability. You're right, the two are going at the same time, and that's the rightful warranty of curiosity. Yeah. Yeah.
That was actually going to be my question as well, because you would expect the elect down. You would hope it's as a result of more activity.
Yeah.
And so, you know, the number of elected the emergency admissions is something that I think I would like to know more about.
Yeah.
What they are, because is this something of a public health issue because people are being admitted for emergency treatment or things that we could be preventing, I think is my plea if we could look into this a little bit deeper. So
I'm happy to take that up. We've also, we're due to reschedule because we have a joint executive session with the Welsh Ambulance Service. So actually we could bring that up when we have it and see what insights they have as well. Yeah.
there is a question, isn't there? Is there something that we can do in this space to improve that? So yes, Nick and I obviously have the same thought. Tracy, I'm going to go to you, and then I'm going to go to Meg.
Yeah, thanks. As ever, really helpful. It's about how this affects the actions and decisions for us, isn't it? As always, and Ian and I have had this conversation. Just a couple of points on that. One, I mean, superimposing activity and modelled increasing demand based on the burden of disease on cities could be really interesting. Because having been involved very young cancer world in Wales, it was kind of netting off a significant increase in demand, but maintaining performance, which was giving without looking at demand, it was given a spurious position, because actually, you know, the pace of improved performance, but actually increasing activity, it was just in a net off position. It would be really interesting to see that. And then when you look at the modelling for some of these, it's just not, it won't add up. My point is about gender, actually. I remember us having a conversation about 15 months ago about real concerns around economic inactivity for females. And it's interesting to see that has kind of somewhat narrowed gap between male and female. But I just wonder at some point, Ian, it may be helpful to do it, maybe pull together a women's health profile on the dashboards, just to see what the gender difference is on a couple of these elements. Because I think, you know, we're hearing it when we're looking at access to services, healthy life expectancy, economic inactivity, although that's just kind of, you know, been a little bit circuitous over the last 2 years or so. But I just wonder whether that would be helpful. I know it'll take a bit of time for the team to do that, but looking at the profile of gender in some of the specifically may be quite helpful.
And Meng, I left you till last because I thought you can answer and then you can automatically lead on to if you've got any update on current issues. So I thought you could group the two together, which is why I made you wait. Sorry.
I have no answers. Some of the earlier discussion, how to make that from but I'm sure Ian will be planning some responses. So I want to draw attention to slides 58 and 59 of the pack, where avoidable mortality is expressed by deprivation. And I couldn't help but notice, in terms of the food rates and the adjusted rates, that there is a spike in the winter months, particularly among the most deprived in town. And it, you know, it can't escape me that that might be related to vaccination. It might be related to other preventable causes which are affecting our most deprived communities. I wonder if there's any further we can do about the causes of mortality, because we've assigned them as avoidable mortality. So what are the causes that we can prevent, and are we doing the right things? Because we do have an agenda, haven't we, around planning for the winter. So just wondered if you use it.
So we have information, the avoidable was quite crude in that it's at the beginning under 75 as being an avoidable mortality that way. But then you then do that specifically, we can break it down into preventable and treatable mortality, and we can break it down into different issues such as liaisons, related, tobacco related as well. So certainly, I don't think it's a lot of it's there on the dashboard, and I could put in a little bit of an overview, but I'll do it properly and get back to you, Meg, and I think it's worth a bit of work with the team on it. So it's a fair point. The other point on Tracy's one on gender and employment, I think although it's often weighted about funding an activity, I take the long-term view. And the long-term view has been an increase in economic inactivities. And I think we've got a lot of this together already. We know healthy life expectancy is being driven by female. We know that elected waiting lists are female dominated, and therefore the increases in waiting lists are likely to be female dominated. And my feeling is that when we tie all this together, then actually what we're getting is very much a differentiation by sex around what the impacts are, with we're working on both to get them into a 2 to 3 page summary and such.
And if I come back, and I think that the evidence of that, you do read then, I know Claire's gone out for semantics to me,
She knew you were.
it's then, well, what's the Women's Health Plan for Wales?
Yeah.
How evidence-based is that? And based on, you know, I know we informed that, but it's just, you know, so once we see that, is there more that we should be doing in presenting this, or activities, or influencing others? We have.
Yeah, and that's something that we can have some kind of further discussions on,
Yes.
isn't it? Thank you, Jim.
Just to come in on the issue of the Women's Health Plan, I think there is more we can do. I think that data would be really useful. But what we've been seeing in work on Women's Health Plan is that women take up waiting list offers differently than men. And I think my hunch would be we underserve, and we need to do better in order to engage, you know, some particular women in terms of getting into an offer and getting healthy. So I would like to see that data, because I think we need to do much more of a targeted offer. There is a question in my mind about whether some women deteriorate in their health status on waiting lists more than men, which accounts for part of the pattern that you picked up. That is a hunch. I can't prove it, but it is giving me cause for concern, which is why I've been pushing the team, you know, our healthy waiting list stuff to kind of do more targeted uptake and advertisement and engagement. I still think there's much more to do, and I think that would be helpful. On the winter stuff, I do think we are seeing people die from preventable respiratory collapse and a variety of other things because they just haven't been looking after that. There is we've seen data from England that's making me ask a number of questions in Wales and similar in Scotland around, are we seeing the same patterns of preventable mortality and what could we do? Which is one of the reasons why we've been upping smoking cessation offers, secondary care, because a number of deaths in England and Scotland have been attributed to collapse, who've been heavy smoke as well, and secondary care waiting lists. So this kind of getting much more nuance, sorry, I'm going on a bit, I think is the right space to get into.
And I think we can probably make more use of our partners and their communication paths, and potentially make use of Llais actually in some of this. And maybe that's a conversation we can have, Catherine and Samina, and then we'll have to move on, I'm afraid.
Thank you very much. So just picking up on the kind of one of the slides in the pack around actually volume of fruit and vegetables being eaten, which seems to be going down across Wales and in the UK actually. And just reflecting on the presentation this morning around obesity and overweight, and that seems like a curious there's a curious trend there. I just wonder if we should be worried about that. And I think does it link then to the cost of living? Is it linked to the labour crisis that we're influencing? So that was my first point. And the second then was around just a flag in terms of women's health. Healthcare Research Wales fund the Women's Health Research Wales Centre. So if you're not linked in, then it's definitely won't be. They're doing lots of research there.
That's great. Well,
I know lots of people there.
if anything we do outside the meeting, that would be really great. Samina, do you?
Thank you. So Samina is our National Director of Policy of International Health. Meg, just on your question about winter mortality, the other thing to flag, which your team are heavily involved with, is the winter pressures work, because that kind of brings together all the work that we do. So pre-COVID, there was quite a lot of work on winter wellbeing, what keeps people well, what, why people die over the winter months. And last year, one of my colleagues, Ash, in the behavioural science team, led a piece of work looking at he updated that piece of work, but then took a behavioural science lens to it. So this year we're looking at, well, how can we build on that? So I think there's an awful lot happening in the winter wellbeing space.
Yeah, aware of it. Just wondered if, what we're doing is going to be dealing with the avoidable elements.
Yeah, I think it comes together there.
That's great. Thank you all very much. Do I take it from all of this discussion that people are happy to take assurance around that we're taking actions on these? We've got a couple of actions, I think, for people to take away.
Yeah.
You're going to do the report on women's health, and you're going to connect in with Jim as well. So are people happy to take assurance from this report? Thank you very much. And I think we move on to the next item in the agenda. Zoe, I'm just going to pass this straight over to you.
Yeah, thank you. Zoe Pietschak, Cafabio Graver or Strategy Guide, Kathleen Bartholmiad. Zoe Pietschak, Executive Director of Strategy, Finance and Performance. So just to say it's great to be here and thank you very much for the more welcome. It's been brilliant. So on the agenda today, we have 5 papers under this item. The first 2 of those papers are an overview of our performance as an organisation for the last financial year, 25-26. And then the final position that we have for performance in month 1 of the new financial year, 26-27. So I'll briefly summarise the performance of 25-26, and then I'll move on to the month 1 report and bring my exec colleagues in to get a bit more detail, bring some of the themes across between the 2 years. And to pick up any next steps and other information as required. I'll also pick up the finance paper under that run through of the integrated performance report. I did just see as to update the board, and as I'm coming new into the role, just to say that I'm going to do a bit of a stock take of how we look at performance and report performance across the organisation, just to make sure that we're taking a consistent approach to the metrics that we use to ensure that we are getting the right assurance around our delivery, performance and improvements, using the best of our resources, and also linking those through to the outcomes. So as part of that, I would also take the opportunity to get clear views from all of our key stakeholders, including non-execs and my exec colleagues as well. And I feel that will come back to the board development session. So just quickly then on 25-26 performance, so that's the performance and insight report on 12 overview cover sheet. So it provides us with a summary of the performance for 25-26. I'm not going to go into a massive amount of detail, and I'm definitely not going to go into all of the areas raised in the report. I did just want to say that kind of generally we're seeing very good performance. We are, though, as we know, seeing some escalated areas of challenge performance, and we will definitely get into some more detail of that when we look into month 1. So 25-26, we have seen a continued and gradual increase in the overall trust sickness rates. I think, again, we'll get into a bit of that when we look at the health protection and screening services challenges, because the 2, I think, are probably related. We're seeing good performance in our statutory mandatory training, which is a continuation. In 25-26, that includes appraisals. We might want to pick up a bit of detail about that in month 1 reporting. We have, as I just mentioned, seen persistent challenges in the delivery of some of the national standards and some of our screening services, so particularly breast screening, bowel screening and diabetic eye screening. And we have got improvement plans developed. So as we talk about month 1 performance, I'm sure Meg will bring in some of the areas of how that progressed and some next steps. We did see one major breach that was reported in terms of our statistical and analytical publication in 25-26, and that was about the early publication and press release of some information that was then progressed and taken forward. But just to note for the board, and we've seen continual good performance in the meeting of the 90% target for health and quick. And then finally, the delivery of 83% of our integrated medium-term plan milestones at the end of 25-26. I wasn't going to say much more about that particular financial year, but I will move on to month 1 of 26-27 and turn to my exec colleagues to pick up any themes for the years and any areas of detail. So we'll go section by section through the report, starting with accountability and governance. And Rachel, shall I come to you for work?
Yes, thank you. Rachel Atwood, Rachel Atwood, Deputy Director of HLAD. So leading off with sickness absence, we're reporting a stable long-term rate across months 12 to 1, but that's against a sustained upward trajectory, which is consistently above the 3.25% target we currently impose. The trajectory reflects external benchmarks and trends, including the increasing prevalence of long-term health conditions and workforce demographics. So we have seen a short-term improvement in month 1 in month absence from 5.2 to 3.8, but there's no structural shift. So as I've said, long-term absence continues to account for the majority of lost days, and we've got an ongoing concentration of detection and screening services. Moving on then to staff demand, as Zoe said, we maintain high compliance levels at 92 to 93% across both periods, and all directorates well above the 85% target, which is a good measure of governance assurance and workforce capability. Our grades of compliance has deteriorated at the start of the new year, continuing a drop off that we saw in month 12. We're at 83.4% in month 12 to just below 80 in month 1. Not necessarily uncommon at this time of year, and we do generally have in-month lags on reporting, but I guess it is a watch point, particularly if we think about some of the stuff that we are hearing in the BTW review in terms of those very important appraisal conversations, which also impact on absence management. On agency spend, continued improvement. Our control feels strong, 0.9% and in target in month 12 and 0.8% in month 1. So yeah, doing where we want to be that.
Yeah. Thank you. Thank you. Brief pause for any questions.
Thank you for that. Thanks for the introduction to reports. For me, it was about the sickness absence that we do talk about it obviously when it comes here. And I'm absolutely sure they're doing all the right, if you like, mechanical processing and tasks to bring it down. But I think, so you just referenced it. It's for us as a board, it's about that triangulation. Things going on around there. Are we now looking at what is that holistic cultural issue that we might have? And how do we get under that and look at it in that more rounded way? Because we have been looking at that for a long time. And just with the other things we now have visible, you're starting to think actually this is just another bit of that triangulation. So it's just, are we going to look at that in that more holistic from this point of view at board? Thank you.
Lynn, did you want to come in?
I don't know if Rachel wants to come in first and then I'll follow up with a specific thing around HBSS.
Yeah, if I may then. And I think you're right, Nick, and I think the nature of the IPR drives us to appear to be looking at it in isolation, when actually reducing sickness absence is an integral part of so many of the programmes of work that we've got in place. But the IPR doesn't represent that. Interestingly, one of our IMTP commitments for POD for this year is about developing an organisational mood dashboard that does triangulate more effectively. So take your point, and I think it's potentially a little bit of a fault with the report. We're also looking at that target. I'm not sure that target is one we need to impose on ourselves, that 3.25%. All the evidence out there tells me we're never going to. So I'm talking to Zoe's team about that as well.
Okay.
I think specifically for HBSS, I'm delighted that is starting to trend down in the recent month. And when you look at the breakdown of this is heavily skewed on long-term absence. So I know we're dealing with a few cases where hopefully there will be some resolution to that that will then bring the absence rate further down. I think we also need to understand the workforce in health protection screening services, that they're not office-based. many of them. So coming into work when you're slightly under the weather is probably not permissible in the work setting, as opposed to someone working from home who might, continue working in a home environment, but still feel a little under the weather. So I think we need to take that into account. And I think a comparator might be to see how it compares with health board sickness absence, for instance. That's probably the triangulation we need to also consider.
And if I can just copy back, I'd be interested where Paul got on with this. For me, it's about the triangulation. For me, it's actually about the long-term sickness, not about the short-term.
Yeah.
I absolutely agree with that comment. And it's about how are we triangulating that with all the other challenges we have in that area, because it feels as though it's part of something bigger rather than it's a sickness absence issue. And I think Rachel, you've given me an inkling that is how we look at it. It's just how we get visibility or get assurance through pod that we are dealing with it at that level.
And I think that's absolutely the case, that we need to make sure that pod looks at, whether or not it's short term or long term. Do we have frontline clinical staff who, what's the comparison with the people who are currently working from home and the people who have got frontline jobs that they don't want to pass on infections. So a little bit more granularity in what that actually looks like coming to pod, I think would give the board a great deal more assurance. And I think that's an action that we can take forward, that goes on to the pod agenda. I'd probably leave that with you, Rachel. It's just to understand, isn't it, what the challenges are, and then what we can do to either, support or try and rectify, depending on where we are. I will come to you in a second, Tracy. Let's go. Quick question first.
Right, it was partly a comment on that, because I totally agree with that. I think it's about, yes, looking at it through the pod, but I think one of the lessons that as a board we probably learned for ourselves is where those different things come together, because actually it's a triangulation of the issue. But specifically in relation to the screening, picking up on Meg's point about actually potentially there will be a higher level of short term. That's also important, but it's important for the establishment, because one of the other things we've learned is that some of the risks come with the fact that we aren't maintaining safe potentially staffing levels because of sickness. We haven't got enough built into our establishment. So if we've got an unrealistic target and and a workforce which is going to be obviously more often, let's just be honest about that in saying the establishment.
Yeah, that will allow us to build a better service as well, won't it? Because we'll have more sustainability. So, Tracy.
Yeah, I think the short-term sickness is always going to happen. I think it's the long-term sickness. I think is the key one. It would be useful, maybe. I know we think we did something last financial year on this, Rachel, but Podcom and maybe at a board level is just do a bit of a deep dive on long-term sickness absence. Looking at the breakdown components, because as you say, we've got 1 in 2 people having cancer now, and I know there's a lot of people in the organisation who have cancer that's being treated at this point in time. So it would be interesting to see that breakdown, because where it's mental health, stress related, burnout related, some of which may be absolutely only work, some of it may be home as well as work. But I think that will be quite helpful at that level of detail, and we can then superimpose that by directorate and what that trend has been in those breakdowns over the last couple of years. So I think that would be useful, but just unpicking it a bit.
Yeah, I think that'd be really helpful.
And that piece of work has been done quite recently, hasn't it, Rachel? So it picked pod in the last,
I think it was
January.
Oh, the January, I thought may have done something, yeah.
Yeah.
Triangulated exit strategies.
So we have quite a detailed breakdown, but I think there is work around culture. I think we've got that kind of granular level of kind of explanation around long-term sickness reasons. But my feeling is, going back to Nick's point, is there something about we have aspirations around the new culture, but I've never really grasped what the baseline current culture is. So I think that's maybe where the gap is. I've never really had an analysis of what the current culture of Public Health Wales or certain divisions are. And so that takes a bit of honest self-reflection, I guess, which is sometimes a bit.
Yeah, we did a pulse survey.
Yeah,
Last year,
we've got the pulse survey,
Yeah.
yeah, but I think I've never, as an outsider, if you like, an insider outsider, never really quite grasped what that. So I hear snippets, but so it's quite hard to know from where are we going. I know where we're going, but I don't know where we've started. So certainly the journey is missing. So
That's good.
we've had this conversation, haven't we?
Yeah.
Rachel?
Yeah, let's continue it. So I suggest we schedule a deep dive in for 12 months after, and what we can do is continue to kind of hone in on what is going to be most useful and just keep maturing.
Yeah, and I think it's just something. It's just we figured it out somehow. We have that stuff, the baseline, if you like. But you know, there's loads of good work gone around where we're going. So yeah, I think that for me that's what's. But we definitely have done the work around the long term.
Yeah, it's our survey and wholesome, yeah, so that's good. I mean, it's good to hear that these things are coming through pod and that through that we can get assurance from the board. But I think it does sound like there's a bit more to do, and I really like your idea, Rachel. So I'm going to say crack on. Brilliant. Thank you very much. I just have one small point actually. It's just about 25-26 performance on ESR, and I noticed that the board it has the worst performance for everybody. We're still above target, but we do have the worst performance. So if anybody around this table hasn't done their ESR, isn't up to date 100%, please have a look at your records and see whether or not there's anything that you need to do or renew. So it's just thought I'd mention that, take the opportunity. Thank you. So we back to you.
Thank you. So I'll move this on to finance. We've got the month 1, 26-27 report on the agenda. Month 1 is pretty light touch in terms of reporting, and you'll see that we've got a £5,000 underspent, effectively a break-even position at month 1, and forecast outturn break-even in line with plan as we'd expect at this stage of the year. The normal scrutiny and detailed reporting for month 2 will be back on the agenda next time. It's just worth mentioning a couple of exercises that we're doing at the moment. So we have, as part of the request in our remit letter, the baseline review work, which is ongoing at the moment and due for submission at the end of June, end of Q1, and there will be some output that will come here. We've also been asked to do a grip and control review across the organisation of our controls and how effective they are, which we are completing at the end of this month and then reporting following that. I'm also aware that there's an action on the action log around capital bids that have been rejected as part of our planning process. So they're not included in the month 1 report, but will be included in detail in month 2. Of course, there are any questions.
Questions?
So we move on to corporate and then clinical governance. So,
thank you, Zoe. Paul Basie, Dewey, as friend of the booth, Paul Basie, Corporate Secretary. So looking at the month 1 position, starting with corporate policies, we've improved the position slightly. So we finished the end of the year with 39 policies out of date, 14 in consultation. By the end of month 1, we are 37 policies out of date, and we've got 19 in consultation. So we've improved the position there. We've also recruited into a corporate policy manager to oversee the management of our corporate policies to greatly improve that throughout the year. So that's heading in the right direction. And you'll also recall we have substantial assurance internal audit on how we manage our corporate policies. So that's looking good. The Welsh Health Circular position is there to see and is on track. Moving on, then you've got the audit tracker, giving our overall position on our outstanding audits. Again, a very strong and stable position there with a limited number of extensions being granted. But the highlight really for my update is the internal audit position as presented to the audit committee in May. 4 internal audits were put to the committee, 3 of which were a substantial assurance, 1 of which was a reasonable assurance, which is an excellent achievement for the organisation to present. We did, however, finish the end of year with an overall reasonable assurance, which is always the balance that tips. But given we have no limited or other lower forms of assurance reported, we'll take it.
He says begrudgingly. Any questions or comments from Paul? No, just a congratulations, I think, on your list. So, it's been nice to see a dashboard with lots of green. So, thank you for that. So,
Shall I come to you for an update on information governance?
Yeah. So nothing particularly I wanted to focus on. I think both the information governance and the service and incidents data demonstrates the growth and control measures that we've put in, and generally we sustain that now, but it does take a lot of energy and effort to try and consistently sustain that. We're seeing a bit of an increase in subject access requests, mainly associated with HR processes. We're going to look at that as a bit of a trend, maybe symptomatic of some of the stuff that we just talked about, and that is taking an awful lot more time. The concerns numbers remains relatively small considering the amount of contacts that we have, but we do readily feedback on trends and some of the particular issues around communication. We will have the compliance with the new regulations going forward, so we're listening to people regulators that are in place from the 1st of April. So the report may look slightly different, but our offer is still the same, fully included in terms of the ambition of the link listening to people regulations.
any questions?
Good. I think we can acknowledge it's a good news story.
Thanks, Claire. We can note that, I'm sure. So it's
Great, thank you. So I'll move on to section 2 of the report, service delivery, and Meg, come to you for an update on the health protection screening services.
Yeah, thank you, Zoe. So in terms of these screening programs, the ones that I know we are most interested in around improvements are breast test Wales, diabetic eye screening and bowel cancer screening. And in turn, I'll just give a bit of a summary of the work that's been done to improve our positions on each of those. So around breast test Wales, I'm pleased to report that we have improved the compliance with the 3-week assessments, particularly in North Wales, where for 2 months in a row we've sustained an improved position to currently just under the 90%, but achieved the 90% standard last month. And in South Wales, we've actually improved the position also. They're approaching the 90% standard, which has lifted the All Wales standard to 63.5%. And this compared with about 8 to 10% early in the year. It's a significant improvement. And that comes with concerted effort, particularly around reducing the time for the first screen to be read, which then dictates whether or not someone is invited to the assessment clinic. This is a fraction of women who are then screened positive who are invited to the assessment clinic. But underlying that is the need to align more towards a 1-week reading time than the current standard is 2 weeks. So if you imagine, if you achieve your reading time within 2 weeks, it leaves you only a week to get the assessment clinic in. So I think by looking forensically at these targets at a local level, the team's been able to achieve this. Now, in North Wales, the position is slightly different, very different. We've not been reaching this target for a while now. And partly this was as a result of the practice in the assessment clinics in North Wales, but following a recent escalation, we've been able to hold radiology-led clinics in North Wales now. And we will continue to work with Betsy Cadwallader, the health board, to understand how we can fill some of the gaps created by periods of absence from the surgical team there. So I don't think that metric will move significantly over the coming weeks in North Wales because there will be a backlog still of women waiting for assessment clinics. And we're continuing to work with the health board to improve the position on an ongoing basis. And I think coming back to the sickness absence, not very resilient to periods of unplanned absence. So it just takes one person in that pathway to be absent to then really affect the figures here. But we are also tracking the maximum period of against each of the regions, so that the teams are able to see what the longest wait is, as well as what the shortest wait is. And the team's also moving towards a single service in terms of reading, because the images can be shared across Wales. So the teams in South and West are helping there is capacity shortage in North Wales around reading capacity. I'll pause there if anyone's got any questions on the screen.
Questions?
If not, I'll move on to bowel screening, and board will know that we rely heavily on health board capacity for screening colonoscopies, and we commission health boards to provide a certain level of activity based on the modelled figures from the screening uptake that we have, which for bowel cancer is actually high. So our uptake and coverage remain above the standard of 60%. One could argue that's not a very high standard, but we're achieving that standard. And we are sending people results within 7 days of receipt of the test kit in our laboratories. So that's achieving 100% compliance of that. However, when it comes to colonoscopy wait times, we're still not where we wish to be, which is within 4 weeks of the test being performed. And the current average waiting time is 7 weeks and a day. Now, we seem to be plateauing against this 22% figure currently. We are working with health boards to ensure that they are in the best position to be able to carry out the endoscopy lists that are required. And we've set up a screening colonoscopy improvement project, SCIP, which has had lots and lots of interest from health boards. And we've got 5 work streams that will cover what's required around workforce, what's required around reviewing the sort of theatre lists that are available, and other quality improvement measures as well. We recently received the plans for improvement from the health boards, and we've rated them ranging from, good assurance to very low assurance, and we're working with them individually through our monthly contracting reviews now that we put in place a mechanism to recuperate any cost for underactivity. And plans are in place to identify how we can use that resource to in-source our own screening colonoscopies. I'm waiting for a report from the team on how that's progressing. But in the meantime, we now have a national mechanism to work across health boards to learn from each other, to put improvement plans in place. And we've got local escalation processes for underactivity and underperformance. Again, I'll pause there if anyone's got any questions.
Thanks, May.
Yeah, just a comment. There's a lot of work going on with the team with health boards. I think it's really disappointing, frankly, of the varying of quality of recovery plans that came back. It's a commission service being funded on behalf of the public, and it's just the numbers aren't moving really. And we moved, as Meg said, we moved from an annual allocation to quarterly now. So last year I think it was about 1 million under activity, funded under activity. Once you've already given it to them, it's quite difficult to actually get the money back. So we're working really closely with the health boards. We have to work as one system, but at the end of the day, we're commissioning a service. So the insourcing option is something that we're seriously looking at. It brings capacity challenges with that, and obviously people need to be accredited in order to undertake the colonoscopies, because it is another level of accuracy given some of the stuff changes. But it's just really disappointing that, okay, there's been a bit of movement, but I think there's a status quo that is just continuing in health boards. And Megan will regroup, see whether it's another escalation. I think it's also important to working with Welsh Government and NHS performance improvement, and doing the accountability meetings with health board. So it may be worth Mengus having a feeding in with them, because it has to be a pincer movement, I think, on this.
Yeah, and I think that's fair, and it's I mean, it's good to see that we've moved from 8% to 22%, but we're failing our population. And you know, the 22% is just not good enough. So we need to do everything that we can, whilst understanding that only this part of the pathway is within our control. So it's a question of, you know, what levers have we got to ensure that health boards can deliver the service that they need to deliver for our population. So we will just keep an eye on it, no doubt. Thank you. Any other questions or comments on this?
So moving on to the diabetic eye screening, pleased to report that we've sustained the uptake against the standard. Standard is 80% and we've achieved an uptake of 80.6%. But of course, the success of having more people coming in is that it then puts pressure on service delivery. So whilst we're working to increase uptake, recognizing that there's an increase in demand because of the rising levels of diabetes that remain unmitigated, this puts a pressure on the system, because what we want to do is prioritize screening for those who are newly diagnosed diabetics in lieu of the people who are coming in for annual or two yearly reviews. What we're reporting in the metrics is the those who are offered an appointment in the last 12 months for those in the high risk annual follow-up category. But there's also the low risk, which now represents about a third of eligible participants, where actually the low risk recall pathway coverage is 77.4%, which is much higher than the high risk one, which is 39.8%. But through the initiatives that the team is putting in place, which includes the use of eye drops, this is an evaluation that's ongoing, that's now been rolled out to assess how that's going to impact on the activity rates in clinics, because if you don't need to use eye drops, then there's a higher flow and throughput in each of the clinics, which we think will be an efficiency gain of about 20-30%, which will make a difference. And continued work on looking at other elements of the pathway to see what further can be done to improve throughput. Now, clearly, if the demand is increasing, and that's increasing because either the uptake's increasing or the number of eligible people is increasing, then there will come a point where we have to ask the question, is this service funded and receiving the resources it needs to? So I think we're at the point where we need to undertake that service delivery assessment to see whether or not we need additional funding for this. Stop.
A real challenge. I've also said it's been underfunded. It's again, when you superimpose increasing demand, projections and capacity, the equation doesn't meet, and which is why we really are looking this year about what does a diversified model done safely. I think Zoe, with you with us, having a fresh pair of eyes of zero basing that the programme as well, because I do believe in, and very rarely do I say this, I do think it is underfunded. But I also think the model isn't fit for purpose, what was needed. It's a combination of both. So I think over the couple of months, the next quarter, we're going to need to bring those two together with something intelligent to engaging with Welsh Government. Because marginal gains are great, but then really not going to meet the needs of the population, because I think the model is challenged. So just to add that in.
Tamsin.
It's kind of linked to resource and maybe where the resource sits, but what are the implications if the screening doesn't happen and people who need the screening don't get the screening? What's the implication that then shifts further?
It's eye, it's vision.
There is a loss of vision ultimately if, the retinal macular degeneration or retinopathy isn't detected early enough, then it won't be amenable to treatment.
And do we have a high incidence of that because our screening, we are not hitting our targets?
That's a good question. So we need to probably do a little bit more work on the impact. My understanding is that we are, doing what we need to do to prevent sight loss. And I haven't seen an increase in sight loss because of the delay.
Because in earlier data, the ophthalmology waiting lists are particularly high, aren't they? Am I calling that correctly on the data? Yeah, I think ophthalmology is very high. So is there a link between the screening, our screening, high waiting list for ophthalmology? I don't know if there's what's the path?
And what proportion of that is that? Because of course, ophthalmology covers all sorts of things.
Yeah,
that's what I'm saying. Yeah, all sorts. So there is a question of what percentage we are.
And then
Maybe we can look at that in a little bit more detail.
going back to Tracy's point about resource, is there then an implication for making a case for the resource at our end of the pathway? Because it's clearly an issue.
It's our end that we're, yeah.
But do we have a case to go to Welsh Government and say, look at what's happening at this end, what's not happening at this end, the lack of resource?
I mean,
So if ophthalmology waiting lists are high, partially because of,
They could have to delay.
yes.
My sense of pathway, if I'm going to take lung cancer screening. So lung cancer screening generates earlier diagnosis of lung cancer, and we refer to thoracic surgeons, for example, for further diagnostics or treatment. But lung cancer early is only contributing to some of the workload of thoracic surgeons. In the same way that ophthalmologists will largely get the waiting lists for cataracts rather than treatment of retinopathy. So this, as a percentage of their total workload, is probably going to be small,
Right.
because the treatment for this is largely laser treatment, which will have a different impact on the workload of the surgeon.
And that would be helpful statistic for us to understand what that looks like. Because
deep dive for the ball.
yeah, and that's something that we could consider is a deep dive into that, because there's obviously going to be some else out there. You've already mentioned with lung cancer, for example, lung screening, for example. So I think we could get some learning potentially here that we could then actually take across our screening services to understand which bit of the population is by us not delivering, if that makes sense.
So if Ian and I can maybe work together on this to understand the impact of the delay. So what duration can we tolerate in terms of the delay, and then the impact on the treatment services.
And that detail would be ideal, like hovering. You go to fix everything.
But I was just going to say that some of that we've asked for through use.
Yes, exactly, and that's my point. So once we've got some more of that detail, taking it through QSIC, I think would be really helpful in the first instance, and then we can discuss whether or not it needs to come to the wider board at that point, I think, if that's helpful. So, okay, moving on. Oh, I'm sorry, Claire.
You're right, ophthalmologists are very pressured and have been before the pandemic, but they are categorised differently to waiting lists for treatment. So they're categorised not as urgent and routine, categorised needs to be R1, R2, R3. I think they need to be now. So they categorise the referrals on receipt. So if there's an imminent issue around sight loss, they put it to P1 or R1. So there is that, I mean, don't get me wrong, that category was still oversubscribed. So there is more of a sensitive categorisation, but it can be particularly around wet AMD, etc. So we should be able to get some quite detailed stuff working with the DU.
That's really helpful, thank you. And and we can take that forward, said through QSIC would be really good in the first instance. Thanks for that. And
Then in terms of the other service delivery metrics within health and the screening services, I don't propose to do anything by exception, but if anyone's got any questions on that, then please.
Any questions? Then it's back to Zoe.
Great, thank you. So I'm conscious of time, just briefly to conclude section 2, I'll come for a brief update from research data for digital policy and international health and the health and wellbeing. So the intro.
So just cover off briefly, it's the first major breach we've ever had was physical processes, and we've worked closely with comms on it. What we found is that we need to do further work to embed the process around statistical policies. They have to go out at exactly 9:30 of a morning to be compliant with the code of practice. The press release, which had the data, went up for 45 minutes at 6:30 in the morning, and that's why we counted it as a major breach. So we're because that's significant both in time early and the amount of time that it was up for. We can't determine whether anybody saw it in that time scale or not. For what we've got, they were working that closely with Zoe and Leah in the comms team in order to make sure that all the team are fully aware of the rules and the ways of working around it. That's all I wanted to mention.
Very enthusiastic comms person. Yes. Putting it on at 6:30 and putting anything on at 6:30.
I mean, the reason we wanted to get it on so we could walk the dog.
For motivation.
Yeah.
Amazing.
On policy and international. So
You were expecting me to go to Zoe and I thought I just.
So just very quickly, what we do in policy and international health is rotate what we bring to board. So what's here are two things. So the first one is with regards to how we monitor our work. So we published a report about a year ago, Investing in a Healthy Wales. So this is what we have done to try and track impact. So I just wanted to highlight that. In relation to the Directorate's work on the Women's Health Plan, so embedding a gender equity approach. So coming back to one of the earlier conversations, and Jim's team's also working on that too.
Thanks. I will continue now.
Jim, anything you find your section 2?
Just a couple of very quick things. So you'll notice on page 35 that the timeliness of first contact for quit dropped in March. That's because we have training days. It always drops when we have training days. So we take the view that it's important for quality to do the training days. But actually we were at 90% or above, apart from 1 month last year, which just happens to be the month we did training days in again. So that's the first thing. So we will get that back up. And the second thing is the exercise referral form program. You'll see that the referrals continue to increase beyond the capacity of the system to actually cope with the referrals. So we're kind of looking at what we can do, and not just to kind of get the difference between referral and final completion done, but actually get a more sustainable system. That's going to be a big piece of work for us. But we think this could be really important.
Any questions?
So if I now move us on to section 3, so our strategic delivery. Just a quick update from me on where we are with implementing our milestones from the integrated medium-term plan. So we are over 90% at month 1 of delivery, on track for delivery, which you would expect this early in the year. We've got a small number of milestones that are flagging amber at the moment, which is largely as a result of external influences. We are, though, in the team is picking that up with individuals to make sure that they've got the right support and to take those forward. We have had, as an exec team, 2 requests through to change milestones, and that's just due to duplicated milestones in the plan, so they were agreed. And then, anything on health inequalities?
Can I just make one point about the strategic plan, building on what you said, Zoe, a bit earlier, is that obviously the IMTP is in Welsh Government, pending. We've got a 12-page remit letter, say how many pages for some reason. And we have a 100-day plan of a new government. There'll be a programme for government of a new government coming through. And so we've been talking about, well, I think the team have already started, but they're just mapping these, because as we met as exec yesterday, we really, and with the board, broader board, are going to have to spend a bit of time say, okay, there's all of this landscape here. What does that mean around priorities? Because with the stuff in the 100-day plan, for example, public health strategy, health inequalities framework, there will be lots of opportunities for us to be asked to do lots of other things, and it can't just be additionality. So I'm just flagging to the board that once we do that bit of mapping, and maybe probably the next board development session, if we've got a chance, then we may need to make some adjustments. And so we just flag that as being something we need to. I've got to catch up with Jacqueline on Monday, so we'll just need to reconcile where are they at, because some of the remit letter may or may not be as relevant as perhaps it was a couple of months ago.
Yeah, it's absolutely worth checking in on that, because new government priorities are not going to be identical to.
And we can't keep adding.
No, exactly. So there is something, isn't there, about a re-evaluation of the remit letter. Nick?
Yeah, I mean, I fully agree and support that. I have always a bugbear about when we keep moving stuff on the plans. We just clear that we're really transparent about that.
Yeah.
Because I think not only do a reset, but as you say, questions are going to come in, new government finds its feet. So let's just be really transparent. So we understand we've moved all of this because of X.
Yeah.
And then we can still have a sense of whether we've got control of the bits we can control.
Prove or not. Yeah.
Yeah, it's just for that. So that we don't get into we keep asking the question, and actually it always comes back to we'll not remember we were asked the A, B, and C. So I think it will help us know where to board.
And it's important, I think, isn't it, for us to be very realistic in the fact that because we have a new government coming in, there will be change, of course, and for us to be agile and adapt to that change, I think is going to be really important. And it's probably sometimes we have to say, well, there's likely to be more change this year, but we wouldn't expect it to happen in that way. So I think that's being realistic as a board.
Yeah.
That's like the tap.
Great.
So nearly there, just another couple of areas. So Samina, shall I come to you for inequalities?
Yeah, sure. So just in terms of inequality, what we're trying to do now is do, again, a rolling programme so that we touch base with each of the strategic priorities over the year. So that's why this one focuses on housing, which happens to sit in priority 1. So next time we'll look at something in priority 2. So what we've done in terms of housing is, first of all, highlight some of the work we've done on health inequalities and housing. Ian's team have done, and this is what we will be trying to use in terms of our engagement.
Nick,
Just one point.
Ian, sorry.
Could I just make one additional thing just for board's awareness that we've had one of the first requests in from the new government is for a briefing on how we monitor health inequalities. We again today.
Ahead of the game.
Sorry, I just wanted to make one observation and to thank Samina and the team for adding links in. I noticed that you did in your combined directorial report as well, so you've got kind of links embedded, so that actually I can go off and read. Thank you for that.
Thank you. It's great.
Thank you. And then finally, section 4, opinion on outcome.
On outcomes measurement, what I wanted to do is remind what we're trying to do here is really set out the framework. We've talked about healthy life expectancy and then sustained outcome measurement. So, and with it, and the rapid overview dashboard is designed to give us that more real-time indicator. Then we've got the delivery metrics, which we've already covered, which are part of our impact. The bits we're really working on this year, and I know my team and Jim yesterday were meeting on policy impact modelling. How can we get much better at knowing from all the different parts we're putting forward, which is going to have the biggest impact in what we do? And then secondly, you'll have seen in the annual statement, we added in a forward programme of evaluation, which then gets us actually to the question about, and it's kind of what you were touching on earlier, Pippa, is actually the evidence is there, but for some reason it's not delivering the impact. Why not? And what is it? And what can we learn from it? However, I think the journey we've got this year is still one to embed this in. We're good at looking at the evidence. We're good at looking at the service delivery. What we're less good at is looking at the latest data and the latest information and how do we use that at the latest evaluations and use that in line with the last conversation about actually just because we said that in the IMTP, we might need to do something different now because of the latest data and how we do it. So I wanted to highlight that we're aware of it, and Zoe and I are picking that up as part of an ongoing discussion.
Sorry.
Yeah, I mean, we had a bit of an exchange earlier. My comment around the outcome measurements, and a lot of them are quite out of date. Which is what you're referring to, but it's part of that when you get into the text that comes later, we make the statements about these things happening, but it doesn't correlate because the information is out of date. So we make statements about adolescent mental health and other things. But if you then go, oh good, I'll go back up a page and look at that data, you go, well, the data's 3-5 years out of date. So it sounds like either we're behind the times or someone's got some other data, which obviously we do have, and it's how we tie them together. The one other point in that is on some of them, we don't know what the target is, and some of them do have targets. We'll get an MR in there and things like that, and it just says we're improving a bit, but we don't know whether we're close to where we need to be or anyway. So I think there's just some things maybe we could look at to make that a bit more informative. But it's the up to date one, as you say, we see earlier data higher up, and then you can down and you think, I don't together.
And I would say we have an ongoing functional challenge with many people unwilling to utilise up-to-date data, but it's part of how we embed this in the system as to how we do it. There are also individual specifics which I'll pick up with you offline, but particularly ones I want to highlight are on cancer registration. We know we've got a problem and it's one of the most delayed, and part of the data analysis register cloud programme this year's job is to pick up how we improve the timeliness of our cancer registration data.
No, I think that's right. The one other I'd say is really relevant to our opening today, and a lot of the adolescent metrics around obesity, around smoking, around mental illness are all substantially out of date. And obviously that's a population where there's quite a more immediate impact. But I suspect there is, we heard it, more up-to-date data. But when you look at the impact, you get confused because it doesn't look as though
Well, we just a brief about measurements.
We had a timing issue with this one, or I think that it was due on the one day before CMP. Yeah, it's out of date. But how could we do the latest CMP reading and it's the
And I'm sure that this question will come up again until we get to a stage where actually all of our data that we gather from different sources is up to date. But I know that you're working on it, Ian. So
it won't be anything too.
Thank you. Zoe, anything?
No, that's it. Thank you.
Lovely. Thank you very much, Zoe, for taking us through that. So we've had 5 reports that we've bundled up together, the 25-26 overview, and it's just really about whether or not we can take assurance 25-26 action.
Strategic plan milestone. Request for change the.
Thank you.
Oh, yeah. Classic.
Yes. So, and it sounds like your iPad is taking assurance as well. So, and also our integrated performance report for month 1, and there's obviously been quite a lot of discussion around that. So are we happy to take assurance from the discussions and the actions that we are taking forward? That's great. I'm seeing lots of thumbs up.
Yeah.
I am aware that we are running late. I don't propose to start at 13:25 the second session because you'd all have a 3-minute break. However, I am going to suggest that we just take 20 minutes, if that's okay with everybody. Okay. And we'll see you all again in 20 minutes time, which will be, well, we'll make it 13:45. That's great. Thank you very much. Is we on? Croeso and all, everybody, welcome back. Sorry lunch was so brief. Move on immediately, I think, to the next item on the agenda, which is an update on the sexual health post test and post service incident, which is straight over to you, Wendy.
Sure. So the written update gives key messages around the developments with the management of the incident relating to the sexual health test and post system. And the board will be aware of light almost 6 months ago now. And in that time, we have been meeting regularly as an incident management team, and for a brief period escalated to an enhanced incident where Tracy chaired a response group to coordinate the complexity of the activities required, which were not just about the look backs for the safeguarding issues that surfaced, but also the health system issues. In addition to that, put in place the mechanisms to provide support to the ongoing service delivery in terms of the governance aspects and also the safeguarding aspects. Update will give you a summary of where we are also in terms of the SHIG, the Sexual Health Improvement Group, which saw the development of these tools, DPIAs and SOPs to support the new business processes. And that's now been stood down as we revert back to normal incident response. The couple of areas that really will need to continue is, first of all, around the best practice advisory group, which Giri Shankar, our Director of Health Protection, is leading and has pulled together a team of people, largely from within Public Health Wales, and that's not for want of trying. We will continue to seek external support to that group as well to determine what best practice looks like for such a service going forward. The other area of work which has been delayed somewhat, which is unfortunate, is the progress with the external independent review. Since board signed off the the terms of reference at the last meeting, we've been looking for the chair. Fortunately, the people that we initially approached weren't able to commit to it, and subsequently we've approached at least 4 other individuals taking this role. But I think the feedback has been it's a significant commitment. I'm still pursuing 1 or 2 individuals, and I think there is a notional commitment that I'll need to just check in on probably later this week to understand whether or not that will progress. Now, this will obviously lead to a delay in the delivery of the report, and we need to give the review panel a chance to get into the detail of the review. So I think we will need to revise the timescales and expectations once we've appointed a chair who will be a critical member of the panel. In the meantime, we're collating the documents and materials required for the panel in anticipation that the review panel will want to start the work as soon as possible. Indeed, one of our members has already begun some of that desktop review, but we do need the chair to steer that from an independent perspective as well. We put in admin and facilitator support for the review panel. So once the chair and the sexual health expert is appointed, then we will be. So this report is here really to provide assurance that there's ongoing management of the incident and progress around the review panel.
Thank you, Meg. Got any questions or comments on this? Still happy to receive this as an update for assurance. Was there anything you wanted to add?
To corral, we've got the majority of the panel in place. We're just trying to corral the chair. Hopefully we have somebody, because it needs to be someone with the right skills to chair it. It can't just be somebody sat on a panel, you know, here's a chair hands. And as much as we've also talked about a non-exec, but it really does need to be external, I think. And the other thing is instance progressing, and we were looking potentially, I think, for the end of June with the view of potentially closing it as an incident as well, so we keep the board updated on that as the two main tracks come to fruition and to a closure. So and we've been able to stand things down gradually. There's still some final work to do with them.
I mean, it's good to see the progress on it. Ian, say something.
Yeah, the other bit just to add was the other part, which will inherently reduce the risk, is about the amount of manual processing that is in the team. And so we've got a programme of work which will continue on, and the improvement group will now go into programme report, programme status, in order to automate what we can within the existing business process. And we'll report that on through the additional portfolio and through Craig, so you've got visibility of the work there.
And there'll be some kind of, when you stand the incident down, there'll be some kind of closure report. I
It may well sort that, and obviously they'll be learning. Valuation debrief.
Keeps informed, I think, is the answer for this at the moment. Any other questions for? No. Okay. Was there something? So just can we take assurance from the report and the fact that we are continuing on with actions? Thank you very much. We'll move on to the reports from the committee chair. They are all here within the papers, and this shows the work of the committees over the past few months. Not all of the committees have met. We've had the audit committee and pod. I don't know, Tamsin, if there's anything that you want to add in addition to the paperwork that we've got. And thank you for that. And Kate, of course, isn't here for any updates on audit committee. Audit committee members, Catherine, Nick, anything that you wanted to bring out of the report?
Traditional year end, going through the mammoth papers on the board.
Thank you.
I just had one thing on audit committee, which is the one bit I wanted to notate, and I think it's important if you we spent time going through the self-assessment on digital transformation audit. Nearly every other health bodies had their report. We've yet to cover, so I did put pressure on Audit Wales around getting something before, but I said, we've still yet to hear anything about when we receive it. That one before that's we get it.
Great. Yeah. Okay. Thank you very much. So are people happy to take assurance from the work of the board committees? Great. Committee annual reports. Paul, I will pass to you.
Thank you, Chair. So yes, first of all, I need to say a big thank you to Liz and the board support officers who put all of the information together that's in this report. It's a really comprehensive report to give us assurance that our assurance process through our committees is fit for purpose. So really quickly, a whiz through the report. It summarises committee attendance throughout 25-26. It outlines our governance arrangements on how the committees will report through to board to pass that assurance up, how the work plans are developed, how we look at action logs and how we manage and track progress against those actions. It also picks out the cross-cutting themes that are passed between the committees on areas where there's a dual interest from different angles, pulls out the NHS P&I assurance that the committees take on the specific areas that we put within the assurance schedule in the hosting agreement. And then you've got some slides that basically form the individual committee annual reports, which have been approved by each of the committees, which summarises the work of those committees throughout the year. Then towards the end, we've got the committee effectiveness process, which is set out in the report, pulls out some key themes that we are then going to work into the arrangements for this year, all of which seem eminently sensible and take us to the next stage. And of course, the caveat is that we have discussed in development whether we have another committee to look at performance and escalation. And of course, that's a development that we will take ahead as well. So the report is here for assurance. The work plans of the committees are also at the end, and they're here for improvement.
Questions or comments? Catherine?
Yeah, sorry, just one comment on the committee annual report. I noticed that on the Audit and Corporate Governance Committee. I'm not named. Should be added.
On
I
the,
was in the March.
on the attendance list.
Yeah.
Double check.
I think you were right.
Yeah, absolutely. Yeah.
Apologies.
Let's go.
Can we make sure that, that moving forward, Catherine's name is included whenever she has a meeting? Post it.
Yeah, I just to say, so this is the first time we've presented it like this. I think it's a really good report. I think it's really good line of sight for the board to give assurance as well to Audit Wales. I mean, you know, we've talked about and actually, as we were saying earlier, this sort of the sources of assurance that performance reporting and, you know, Paul and Zoe working on that as well. But I think it's a really well compiled report. So really helpful for us just all with doing our own audit trail, as I'm saying, but I think it's really useful.
Well, you've stolen some of some of my thunder there, because that was going to be one of the things that I was going to say. Was I thought this was a really brilliant report, bringing together the work of the committees, but I really like that kind of cross-cutting themes and some of the sort of discussion points for the future as well, which I thought it brought it all together in one place. I thought it was a really fantastic report. So thank you very much to you and the team for that. Nick, did you want to?
So basically watching it over the years get better and better. I think this year really is good, and I like the cross-cutting bit at the end and the lessons learned bit. I think comes out so much clearer than we probably have in the past. So I was same thing. It just gets stronger every year. It's really good.
Yeah, I think it's a really good. I think it's a demonstration of good governance in practice.
Yeah.
And what we would seek to have as a board. So thank you very much for that. So first of all, I'm going to say, just from what I hear, take assurance from the work of the committees, from what they can see in the paper here. And I'm hoping that you've all looked at the work plans for the committees and are happy to approve. Yes. Yes, okay, so we can take that as an approval. Thank you very much. Thank you, Paul. Okay, so next item on the agenda is the uptake of the public inquiry around COVID-19. So, Meg, I'll pass this to you to start.
Thank you, Pippa. So, board will be aware that the UK COVID-19 inquiry has concluded its evidence sessions and is now in the process of publishing reports, of which four have now been published. So the ones around modules 1 and 2, just a reminder, were to focus on the civil contingency structures, and also in module 2 around governance and decision making and scientific advice. What we've done is reflected on the recommendations, many of whom were for Welsh Government and UK Government, but they were obviously relevant to Public Health Wales as a key Category 1 responder under the Civil Contingencies Act. And what we've done in response is we have taken stock of the recommendations and delivered a revised emergency response plan, which was referenced in the Chief Exec's update today, and also creating a pandemic preparedness task and finish group. People from across the organisation to review our response arrangements, culminating in the establishment of a draft version of our pandemic response plan, which we then used in Excite Pegasus late last year. As a consequence of that, we've also taken the opportunity to strengthen our EPR governance arrangements, committed to a full schedule of training and exercise for in Public Health Wales, but also exercising in Wales as a system, and also instituted a lessons management system, which is reviewed regularly in the EPRR meetings. So I won't go into much more detail than that, which is but the papers here really to provide assurance that we're acting and reflecting on the recommendations and lessons learned from the COVID inquiry on modules 1 and 2.
Thank you, Meg. Just a brief welcome to Hugh Williams, who's joined us online just to support this this item in case there are any questions. Welcome, Hugh. Nice to see you. Do I have any questions or comments, Nick?
I mean, just one question. I mean, obviously, there's a huge amount of what goes into this. I appreciate that. And I think it's really good and clear. I've got one question coming from my bit, which is in T.2. We talk about digital maturity and infrastructure identified as a risk. And I just wanted to check, there's not an assumption here that the work that we're doing around the health protection project, does that cover all of that lack of maturity, or is it a wider piece? I just want to make sure we don't get myopic and just look at the health protection and think it fits all elements that might be hidden in that very broad statement. And I just wanted to check whether we had a view on that.
Probably come to Ian.
So digital health protection is part of it, but not the thing. There are other aspects in the data analysis, registers and cloud, which cover how we do our surveillance activity. But then wider, there is also things which actually sit within Welsh Government remit as well, and also DHCW. So particularly in my heritage, just to reassure you, we're thinking wider about it. It's one of the big pressures if you get to a pandemic is, do you have enough bed space, etc. So it's how do we get the right information, right reporting during the last pandemic? It's access to information like bed capacity, really problematic in the early days. So we've got work with Flynn Jones as the Chief Digital Officer, and he's convening a group which meets regularly to look at how we make sure we've got the right people to get access to that right information. So I did want to assure you we're thinking broader.
Right, so we're confident that we do have an understanding of all the bits we need to fix.
Yeah, excellent. Well, we're confident we understand all the bits we need to fix, but not all of them are for us to.
Yeah.
Yeah.
Understood. Yeah, just want to make sure we weren't just seeing all in one project. Excellent. Reassuring.
Yeah, and I think the reflection from our COVID response is that our capability and capacity to modelling was quite limited, but Welsh Government put in the resource to do that in a sustainable way. And I think what we just need to check with them that is the commitment going forward as well.
Thank you, Chair. So just to update on top of what's been today, that obviously the Module 4 report on vaccine and therapeutics was published on the 16th of April. And I went to London with Chris Johnson to receive that report, 5 recommendations. No specific mentions of Public Health Wales, and the recommendations again are very government focused. There is one recommendation which does link us in, and that is the requirement or the recommendation that each of the 4 public health organisations across the UK should work together to maintain an accurate UK-wide insight into the state of vaccine and uptake hesitancy, and understand the measures proved to be effective in increasing uptake across the 4 nations. So that report is going through the process of internal consideration, and an update similar to the paper that Hugh's provided to us for 1, 2 and 3 will be coming back to board for Module 4. Module 5 is the PPE module. We're not a core participant. Report out on the 14th of July. Module 6, care sector, and Module 7, which is test, trace, isolate, and then 8, 9 and 10 next year.
Take a long time to get through all of this.
And sorry, and then of course the new government has outlined that they'll be reviewing Wales's response to the pandemic. So that's yet to be determined and will no doubt generate further work. Yes, sure.
I wasn't sure if we're going to do it separately. So on the Module 3, I've got a question. I'm going to go on to that separately.
Hey, do you want to ask that, or do you want to go?
We haven't presented the Module 3 one.
I thought because we're on at 4 and 5, we might miss it. I wanted to make sure we get. Module 3, very important.
Shall I proceed then? I'm sorry, Hugh, I didn't realise you were John near the call, so apologies. But can I maybe ask you to talk us through the Module 3 summary that you've done? It's an assessment of what the implications are for Public Health Wales, and you've summarised it beautifully. But can you give us a summary, thanks?
Thanks, Meng. Thanks, everybody, and thank you for inviting me to come and give a quick presentation on. So I won't repeat the report in any length. Hopefully, you've had a chance to look at it. But obviously, this paper, what we're trying to do with this paper is summarise those key findings from Module 3 into the impact of the pandemic on healthcare systems. As you'll know from reading it, that overall conclusion was that the UK really did enter that pandemic underprepared, and the healthcare systems really were put under significant strain. The inquiry itself, through this report, identified several critical key weaknesses, particularly in areas such as infection prevention control arrangements not being sufficiently robust, impacts around patients. They were really significant around the treatment of patients, delays, disrupted care, restricted access to services. Before we even get on to the visiting restrictions and the challenges that posed for people and the distress that it caused. Beyond that, then it's the significant workforce pressures, the severe and sustained disruption there, the levels of stress that put people under, burnout, the trauma, all of the things that we experienced and were really challenged by as organisations through the pandemic. The inquiry also goes on to, in this module, to talk about the longer term consequences here, including the care backlogs, the disruption into non-COVID services, and that widening of that inequalities gap that we were seeing develop in terms of vulnerable groups. 10 recommendations from this particular part of the inquiry in Module 3, and they're all around strengthening future preparedness again, focusing on improving infection control, strengthening workforce, data systems, etc., and really trying to improve in this area of work. From a Public Health Wales perspective, again, just as Meng said a little earlier about modules 1 and 2, recommendations in this space aren't, again, directed at any one particular organisation specifically. They are very much system or government level recommendations, but they are relevant. And from our perspective, we have already made some really good progress in areas such as IPC, data capability, and workforce wellbeing as well. We've made good strides there, as we've already reported through other earlier report modules as well. Key message, though, picks up on what we were just saying. The further development and improvement really now depends on national level decisions and sustained resourcing of the areas where further improvement needs to be made, and coordinated action across the wider system. So we're already doing an awful lot more in terms of helping across the system to be more coordinated, and it's really, really important that we recognise that. I think probably it's important that we just remember that embedding that and strengthen our preparedness for future pandemics remains that system challenge, and making sure that everyone continues to stay on top of what they need to be able to do in case we face a similar set of circumstances in the near future. I'll pause there. Meng, is that okay?
Perfect, thank you.
Thank you, Hugh, and thank you very much for the report, which really draws together a lot of complexity into something a bit more manageably right-sized. Nick.
Thank you. Thank you for the report. I mean, I think it's really good, really clear, and brings out both what we are doing, what the system needs to do. It's a question that may have been answered in another one of the modules, so I'm just doing this because I'm not sure. There's some degree recommendation either about increasing capacity in the health system, maybe hospital capacity, but what about diagnostic capacity? Does that fit in there, or is that being dealt with somewhere else?
So test tracing is in module 7. So that report will come out later in the year, as Paul indicated. So there may be elements there that will look at diagnostics. So it wasn't within scope of this module 3, which was largely about healthcare services in terms of treatment services rather than diagnostics.
That's what I was trying to ascertain. Is it specific about treatment services?
Yeah,
that kind.
There may be a little bit of the procurement one as well, possibly, but yeah, it's been test, trace and isolate.
Okay, so perhaps save your question.
We can look out for group 7.
Yeah.
Yes. Next, we will go to the
Any questions around this?
Not a question, it's the comment. So in my conversation, CNO has tasked some specifics within the IPC recommendations around harm. That's just making sure that we've got that resilience really, because harm is not a massive team. There's quite a big challenge going on with the current IMTs that we've mentioned earlier It's just to make sure, because there'll be a lot of expectation around that in its readiness for any further pandemic, but also in relation to other sectors. So there's already quite a lot of pressure coming around that. It is referenced in the paper, but just wanted to make a note of it.
Thank you. Anything else from anybody? No? Well, thank you, Hugh. Thank you for attending and for taking us through that, and also for the very clear report. Much appreciated. Nice to see you.
Thanks, everybody.
Thanks to you. Okay, moving on to the next item. Before we move, I guess we probably need to just receive those reports for assurance. I'm seeing lots of nods around the table, and we look forward to
Certainly do.
the remainder of the. So, okay, moving on, minutes of and action log of the 6th of March. Was there anything that you wanted to pull out at all?
Only to flag that Catherine's not identified in this image. So we will duly other than that.
I hadn't spotted that way.
Other than that, open for comments for approval today.
Any comments on the minutes? People happy? Are they accurate? Okay, given that they're accurate, people happy to approve. Thank you very much. And could we please note the action log? There are 4 items identified for closing. Paul, is there anything that you want to add to those?
There's 4 for closing. Just to flag on the first of those actions, closure, Zoe has updated us on the IPR review today that the capital discretionary scheme is going to be added for month 2 financial reporting. So on that basis, that's proposed for completion.
People happy to approve the closure of these actions? Yes. Okay. Thank you very much. Next item on the agenda is ratification of the chair's actions that have been taken since the last board meeting. Paul?
Thank you, Chair. So there's two chair's actions have taken place. One was a NHS P&I chair's action for the remote patient. And then the second was a technical negligence claim, which required a concession on liability and a settlement authority. And they're here for ratification by the board.
Everybody happy to ratify and approve the seal? Thank you very much. Yes, that's approved as well. And there's some items really to note, but if anybody has any comments or questions, I'll take them as a group. We've got the report on the matters that were considered in the private board meeting on the 26th of March, and the board forward plan, which any changes of that board forward plan have been highlighted for us, and I don't think there are any attached private board papers. So if there's anything that anybody wants to raise on any of those, now is your opportunity. If not, we take them for noting. Thank you very much. And it is end of meeting time. So is there any other business from anybody they wish to raise? No? Lovely. We will have our next meeting on the 26th of June, and times and links and things to be sent out later. And the next board meeting on 30th of July. So thank you very much, everybody, for your.
Well, shared, finished early.
Oh, 1 minute.